Welcome to everybody. Thank you for joining us today at this event from PDPAL project. Okay, these events are part of a series of webinars that will take place in the next few months and are organized by the PDPAL project consortium. PDPAL project is a project about palliative care for Parkinson's disease and is funded by the Horizon 2020 program of the European Union. We are very happy to start this series of events to communicate and spread the voice about the mission of this project. We are pleased to have today with us Savela Martinez, an outstanding figure in promoting awareness, inclusion, and also research in Parkinson's disease. She is a great translator and reviser for United Nations, and she is very actively involved with her website Con la Pede Parkinson, a platform thought to bring together women and offer them a space for sharing experiences. We have also today with us Prof. Piret Pal, and she will be our moderator. The focus of today's webinar will be getting on with life, living with Parkinson, with a special emphasis on women perspective. I will now get a brief introduction about our project. So the PDPAL project is an ongoing project. We are still 8 months ahead. And we decided to start this project focusing on Parkinson's disease because it's a scenario in which palliative care needs to be improved and spread. In fact, PD patients have considerable and mounting unmet physical, psychosocial, and spiritual needs that needs to be addressed. We have different barriers and challenges to face, and one is particularly a linguistical challenge. In fact, the problem is that palliative care is understood as synonymous of end of life or terminal care. So our overall mission is to validate a new model of palliative care that needs to be integrated with the traditional management in Parkinson's disease, and especially in the healthcare. We're doing that not only involving healthcare professionals, but also patient caregivers, and also our mission now is also to involve more and more students from healthcare professions to be familiar with this concept. Our consortium is composed by 10 partners from 7 different European countries. We have recently been joined by Region Skåne of the University Hospital in Lund, Sweden, that has joined our ongoing trial. We have a lot of partners also from other associations, like the European Association of Parkinson's Disease, the EPDA, and also other projects like the iCare, which is also a European funded project that is also trying to improve care pathways for Parkinson's disease. Our objectives are to reach an improvement in palliative care in Parkinson's disease, and are to develop guidelines and recommendations to understand better when palliative care should be addressed and delivered. And we are also doing a clinical study to address the importance and efficacy of delivering a community care-based on nurse intervention, which is aimed also on taking control and better care of patient symptoms and everyday life, but also allowing a patient and caregiver to think about disease course and their willing. And of course, as I said before, our project is also a development of a palliative care massive online open course that now is actually in the pilot phase and has been tested by several students. You can have more information going to our website, pdpal.eu/MOOC, and I ask you maybe to take part of this process and join this course that will be officially launched by end of June. I will thank again all the partners that are part of the project consortium, and thank again the European Commission that is funding us, and the PDA also, and also our speaker today. And I will let the stage to her. And so I hope you enjoy the webinar.
Thank you. Thank you so much for that presentation. It's a pleasure to be here. Welcome, everyone. I'm Isabel Avion, as you know, and I'm a person living with Parkinson's disease. And I'm here to tell you a little bit, as you've heard, about my story and things that I think that I can share and that I've been sharing. And I will be also sharing my screen, as you can see. And so, as I said, welcome again, and thank you for this invitation. So, I'm from Galicia, which is in the northeast of Spain, and I'm going to show you here so you get an idea. That's it. That's where I'm from, and we are a very superstitious people, very, very much so. And I'm going to show you an example. Here you see, this is Santa Marta de Ribarteme, and the people that you see in the coffins are actually very much alive, but they have asked Santa Marta, Saint Martha, for a favor, usually to heal them from a disease or to spare them from dying. And they say, you know, if you grant me this wish, I will go to the procession inside a coffin and I will be paraded in the town. And when we look at this picture, we can think, if what is this? Is this a symbol or a depiction of deep faith or of failure by science or medicine? What is this exactly? Do we give as much credit to science as we give to Santa Marta in this case? So you've probably seen this picture before. This is a drawing from 200 years ago, when there weren't that many options to show how Parkinson's disease looked like. Parkinson's disease is this. Yes, it is an old man with that posture, and a white old man as such. But now we're in the 21st century, and I can show you how Parkinson's disease looks like also, which is this. So in order for me to be like I am today, like you see me now, I have to adjust my life. I had to get up 2 hours earlier, or rather I had to take my pills 2 hours earlier so that they would kick in time for me to be able to share with you this picture. And here you see a bunch of friends. You see Omotola, you see Paki, Marta, Yes, Larry, Iñaki, Christine. You also see Michael J. Fox, not that he's a friend, but he's someone that you probably recognize. And you can also see Kamal, who was here shown running the New York City Marathon in November 2021. She does live with Parkinson's and with epilepsy, as you see. So when we were told that what we have is young onset Parkinson's disease, YOPD, things begin to wobble, right? When you get this idea, you start thinking about your job, your family, your children, your parents, like mine, who are in Spain, an ocean away from the US. You start thinking about mortgage, about future, about rent, about what to do. So you think, and what do I do? What's life going to be like? And going back to the medication that I told you earlier, the main one that I take is levodopa, and it literally gives me life. It's what helps me be here, have a functional life. And levodopa has been around, as many of you know, for 50 years, 50. And that's a long time. It's been more than 50 years, actually. Think for a moment all the things that humankind has achieved in the past 50 years. I'm going to challenge you a little bit more and think for a moment what humankind has achieved in the past 50 months. So let's go back to my friends here. So when we were told that we had young onset Parkinson's disease, as my friend Sonia says, we had all the answers and they changed the questions, which is a quote from the spring of 1968. Did you know that more than 40% of people living with Parkinson's in the world are women? And that more often than not, they get diagnosed very, very late, because with all the things that we have to do, we don't have time to go to the doctor. And PD is a mystery. Parkinson's disease actually qualifies to be an invisible disease, the one that you don't see. And you can even begin to imagine how complicated things get when you're a woman under 50, like I was in May 2016 when I was diagnosed. It is estimated that there are around 7 million people in the world living with Parkinson's disease. And remember, about half of them are women. On top of that, at the doctor's office, they tell you Parkinson's disease in young women is very rare. There are very few cases and far between. So you leave the office thinking you're a rara avis, you're the odd one out. There's no one else like you. You go home, you Google women and Parkinson's disease, and depending on where you are and which language you speak, and I specifically highlight the where and the language because there's a gap in how information is available. Depending on where you are and which language you speak, you find yourself sometimes in the middle of nada, of nothing, of nothingness. And you start thinking, perhaps it's true, we don't exist. Remember, I said we're about 3 million, so we do exist. So where are we? And as you know, and these are terms that you've heard often in palliative care, our self-perception gets smashed. We have a new sense of identity. We lose our previous sense of identity. We're faced with an emotional challenge and sometimes even social isolation. We start wondering, if we hadn't before, about the meaning of life and our purpose. How can I maintain my sense of self in the face of this? How do I reinvent myself in the face of this diagnosis? Well, let me tell you how I did it, how I do it, and how many people do it. And in 2020, Paqui Ruiz started a blog, and she called it Con P de Parkinson, which translates to P as in Parkinson's. She often says that she opened a window to get some fresh air, and it was a tornado that came in. The blog grew, and it's now a non-for-profit association. And we give voice to Spanish-speaking women living with Parkinson's disease. And we are a platform, and from this platform, we fight to give visibility to an invisible disease. We promote and encourage research with a gender perspective. And we want to share stories and testimonies which help improve quality of life. We work on visibility through our blog and through our radio show. On our blog, you can find posts about intimate, private stories, very personal, and about other practical things, more trivial, perhaps, like tips about traveling or how to get dressed or how to put makeup on. Then we also have articles by healthcare providers, by researchers and scientists. And sometimes we often also, I should say very often, we translate articles from other languages, mostly from English. Goes back to my comment about how and where you find information. And our radio show is called Onda PK, and it's on YouTube and also on a podcast format. And there we have specialists and patients having candid conversations. And our most watched show was how to get prepared for your visit to the neurologist. And it includes a role play interview with a movement disorder specialist. And it's been quite popular, as I said. We also participate in international events and activities, but most of those are in English. So our participation is limited. And it's not only our participation as an association, but also of the women we give voice to. They also see how their participation is limited because of language constraints. When we talk about research, we could talk about research at length. And we are very, for us, it's very important to talk about research with from a gender perspective. And I hope you don't see this as feminism, because that's not at all what we pretend. That's not at all what we imply. It's a fact. Our bodies are different. And I'm not talking only about the physical look. I'm talking about the chances of having more serious or more frequent liver failure in women when they take Tylenol. But that's because our livers process Tylenol differently. Or about the fact that in the US, for many years, some women were overprescribed zolpidem because we don't need as high as a dose as men need. Let me tell you, and this is where this picture came in, a little bit about my experience in research. I've done countless research. I participated as a subject, which is a word that I hate with a passion. I prefer partner or any other, but not subject. And as I said, so that's what I realized at the beginning, that there wasn't much that I could do other than take my medication, exercise, and see my care team. But I could participate in research. I could volunteer. So I've done the scratch and sniff test a million times. Probably you're familiar with it. I've been inside an MRI machine, again, countless times, even managed to fall asleep once. This is an actual picture of my own PET scan. This is how it looked like a few years ago, 3 or 4 years ago. And I've also done the neuro tests like this, not a million times, but close enough. So much so that this particular one, I'm not allowed to take it anymore because I know too much about it already. So as I said, I've also given blood, saliva, skin cells. I've had my eye movement recorded. I've had my gait recorded. I've had, what other things? Oh, and I've completed countless surveys. Those are the easy ones, surveys. Right now, at the time of this recording, I should say, there's a survey being done from Spain, which is the first ever survey done in Spanish for women with Parkinson's. And it's been done out of the Valdebron Research Institute in Barcelona, Spain. We're very excited about that because it came from an idea, a suggestion that we presented to the research team, to Ariadna Laguna. And as I said, I realized that if we want to be in research, if we want to help, we have to be there. Without us, there's no research. Without us, PDPAL cannot see how far they can get. And they can get very far, I'm sure of that. But not only patients, not only people living with a condition, also those of you who could be healthy subjects, control subjects. Again, I know I keep using the word subject, although I hate it. So when we talk about research, as I see it also, there are 3 fundamental concepts that you've probably seen before: participation, engagement, and involvement. Participation is really, I go, I give blood, and I leave. Research is done to me. That's all. Engagement is when you go and you share what you're doing, your research and everything. Involvement is when it gets interesting. Involvement is when you get the patient to help you, for example, shape the way that your research is going. And I'll give you a real example, but with a fake example, really. Let's say that you're writing the instructions for patients for your research part. You look at it, you've been working on this for many months. You know everything. Everything's clear to you. Those are the instructions. This is what you need the patient to do. Wouldn't it be nice? For example, let's say that you have this sentence. You look at it, you run the spell check, there are no issues, but you might need a second pair of eyes coming from a lay person, in a patient, for example. This is an invented example, by the way, so it's not real, to tell you that there are a lot of problems here. Just an example to show you that you want patients involved in how you do research. And also, speaking of research and therapy and treatment, it often happens that the psychosocial aspects are overlooked. And what this means is that the research, the therapy, and the treatment are incomplete. We, people living with Parkinson's, we want to see our quality of life improved, also from that less tangible way. Now, quality of life, that's the question, isn't it? Whether you have Parkinson's or not, it affects you directly or indirectly. Improving quality of life is something that we all aspire to. I was quite surprised with the definition by WHO. You've probably seen it a million times, if not more. But I was surprised, I said, because it has to do with perception. It has to do of perception in a specific context in relation to personal matters. And I thought, wow, this is not easy. It's not going to be easy, not easy to define. What is it? If someone asks me what quality of life is, it's an assessment that I do of myself, of my material world, my social world, my relation with the environment. It's about how happy I am with my situation. It's about assessing my physical health, my mental health. It's about all these things. And then there's also the health-related quality of life, But again, that's also subjective assessment. So how difficult it is to measure. And improving quality of life does not necessarily mean, for example, that if I move to a mansion in the Mediterranean, my life will be better. Because if I still have problems to sleep, which is very common in people with Parkinson's, then my quality of life won't be better. Improving quality of life is almost like a self-assessment, like throwing all the elements on the table and looking at them and analyzing them. It's almost like sorry, I went too fast. I do use a lot of examples with Lego. Yes, you'll indulge me. It's like looking at all these pieces of Lego and saying, okay, looking at your needs, and there might be some needs that you recognize that you hadn't fully grasped before. Where's that piece of Lego that I need right now? Where did I put it? Or it's also an economic matter, a financial expense that you cannot afford. I really need that Lego piece, but it only comes in a 300 euro Lego set. So it's not easy to look at all of this. So this is why palliative care is important from the beginning of a diagnosis. And this is why it's important also to fight that linguistic issue that palliative care is not only end-of-life care. Palliative care, as you very well know, or you're learning, it implies going beyond the physical. It implies going into psychosocial and spiritual needs. It's been proven that palliative care diminishes stress, grief, and fear. So it improves our quality of life. And many people think that palliative care only comes from priests, pastors, nuns, monks, but that is not true. It can come from other people. Because at the end of the day, palliative care is about self-perception, personal beliefs, spiritual well-being, and many, many more things. And here come my 3 favorite words when we talk about palliative care. It's about empowerment, autonomy, and dignity. It's about finding opportunities to be happy. Recently, I met this woman. She's a breast cancer survivor. And she said that the best year of her life was between her diagnosis, two surgeries, chemotherapy, and being declared cancer-free. She calls that the best year of her life. And this is because she's been empowered. She has dignity, and she has autonomy. When we have all that, our perception of the world, our perception of our chronic disease changes. I won't be able to control how long my own time lasts, but I'll be able to control what I do with that time. At Compé de Parkinson, we call this the P attitude, the actitud P. We're not naive. Let me tell you, we often talk about our dark moments, our off moments, and how we feel disengaged and isolated sometimes. It's not all about rainbows and unicorns. I think what it's about changing the narrative so that Parkinson's disease loses the stigma that's stuck to it. And people don't have to decide, for example, whether to make their condition public or not. We should be talking about Parkinson's disease and how it permeates everything in our lives and those around us. We should be talking about reasonable accommodations without fearing the reaction at the senior level, but also among our colleagues. I don't have to worry about what my boss thinks if I request a reasonable accommodation. By the way, the reasonable accommodations are defined and established and supported in the Convention of the International Rights of People with Disabilities. I invite you to take a look at that. Anyone who's still working, like I am, should know what's available to them. And if they don't, and if you speak English, here's an example of a place where you can go. It's Ask Jan, the Job Accommodation Network, where, for example, this is a list of reasonable accommodations for people with Parkinson's, specifically for the symptoms related to spasms, tics, tremors, or blinking. And supervisors should know also what's available, and they should be given the flexibility and the budget to provide to give this to their employees. Now, I'm going to shock you with something. Most of these things cost nothing, zero to the company. And if they do cost something, it's under $500. And this has been done, this has been researched. It's not just me making it up. In any case, And these are just some examples. I mean, there are hundreds more. Of course, you can go symptom by symptom. And in the middle of the pandemic, I was interviewed for a book featuring the story of people with young onset Parkinson's disease. One of the questions I was asked was, where do you see yourself in 5 years? Well, in Parkinson's, that's a very funny question. You don't ask that question. You shouldn't be asking that question. We barely know where we're going to be in 5 months, or in 5 days sometimes. And the thing is that day-to-day life with Parkinson's disease is very unpredictable. You know how your day starts, but you very seldom know how it's going to end. And this is why, going back to empowerment, dignity, and autonomy, these 3 concepts are very important for people like me living with a chronic disease. This is why doing everything possible to develop them, to encourage them, to protect them is also treatment, is also very important. Palliative care brings spirituality and beliefs, the intangible, to science, to the realm of science, the tangible. It highlights the importance of human beings as a whole, not just as a body. Perhaps everyone would give more credit to science and less to the coffins at Santa Marta if palliative care was really fully understood. Thank you very much.
Thank you so much, Sabiela, for sharing your experience. And as a researcher, I always I'm so honored if I can really listen to patients and learn from their experiences. So it's each time many thoughts, of course, come up, and on the other hand, also many patterns repeat themselves. And one of those patterns that repeats, and what you also mentioned, is just understanding what it means to live with a chronic disease. And you said that it can be empowering. And when I think about clinical assessments that is offered to patients or people with Parkinson's disease, for example, all those assessments, in my opinion, are very much needs-oriented. Has ever anyone also worked with your resources in clinical setting and asked that what you have already at your disposal to cope better with your chronic disease?
Well, that's a very good question, because the short answer is no. Like the immediate answer is no, but also I should say yes. Yes, because of what I do. Like I consider myself an expert patient, or patient expert. So I try to have a trust relationship with my medical team, with my care team, with all of them. So I've been telling them, I've been teaching them, I've been communicating with them, all of these things. So now that they are aware of the resources, they also sometimes they might ask me about them, or I know that they share them with other patients. So that's when I know that we've accomplished things, when they are sharing our resources with other patients other than with me. So that's been super important. This communication, that I know that they will come and ask me or ask any of their patients what they need. But it's a learning process, because usually also they don't have a lot of time, right? When you're in the clinical setting, you might have a few minutes only to talk to your patient. That's also why we emphasize the importance of preparing the visit, so that you can prepare with a list of questions, with things that you want to clarify, so that you help also your doctor or your care provider, if it's it can be a physical therapist or any other one.
Mm-hmm. Yes, I just want to emphasize that it is also very important to build this relationship with your patients and to have the trust, and it has to be mutual. You saw in this guideline for the patients that there has to be adherence from patient's side, yes, and you also said in your talk that my role is here to take the medicine and to do sports or, practice sports. And then, we don't know what happens, but that is like kind of my task. That's what's offered to me. And, but yet you spoke about all these Lego pieces that, that make your quality of life complete. And, there is something that comes with chronic disease, and it comes pretty early, I think, and it is such an important part of coping is the anticipatory grief also. And you are not as a patient lonely in this situation or alone. You have your family members, you have your friends, your colleagues, and they all are more or less affected by this anticipatory grief. And it would be great to hear from your side that what have been the coping mechanisms, because you could also resign and say that, now I have the disease, I am not going out anymore, which happens to many patients. I am not living my life anymore. I withdraw myself. I'm ashamed to go outside. So you look like someone who has worked with anticipatory grief to me. And so how does it go? How do you do it? What helps?
Well, of course, I won't lie to you. I do have down moments and bad moments, of course. Over the years, what I see is that, and this is my own point of view, and of course, not everybody shares it. To me, it's not worth it. It's not worth it to stay home, to do nothing. Of course, sometimes I do stay home and I do nothing, but that's not how I want to spend my energy or my time. So that's why I'm involved in all these initiatives. I also sit on the steering committee of iCare PD to give them the point of view of the patients. And so this is my coping mechanism is activism. It's advocacy, it's outreach, it's telling anyone who listen what we do, what we need, and how our lives are. So of course there's been the therapy part. I do have a therapist that I see regularly, of course, which is very important. Also because, for example, in our culture in Spain, at least, there's a lot of stigma around mental health. So people don't think immediately about getting a therapist in that sense, in the sense of the mental health sense of the word. So that's another stigma that we have to fight, because you do need support. You do need to talk to someone from the beginning of the diagnosis. I did speak at the UN. We have staff counselors, which are usually psychologists. So I did speak to someone at the beginning, but not everybody has access to that. And people should be able to have access to that easily without having to think too much about it. And that's okay to need that. So those have been my coping mechanisms. Of course, as I said, when I got my diagnosis, my parents are in Spain, I'm in New York. So that wasn't easy. That was very difficult, because the anticipatory grief also coming from your parents, they don't expect, the usual reaction is, I would rather have that happen to me than to you. So that we had to work through. And then also sometimes, when you're giving the news to a friend, you end up consoling the friend because they get so upset for you, but they feel bad for you, and you end up having to be the one cheering them up. And this is also that I've heard other friends in the Parkinson's community that they say that it happens to them. So we have to learn also to turn the tables really quickly. But those have been mostly. I want to also emphasize the importance of having a tribe, a network, a community beyond your usual friends. Having some Parkinson's people in your life is also important, because they know what you're going through better than anyone else. So it's important also to have that, and they don't have to be nearby. As we know, we have all these means of communication. Ideally, they will be nearby, but if that's not the case, there are options.
Mm-hmm. Yes, thank you. Yes, this is interesting geopolitically, of course, because you say that the internet is at your disposal and you can build those networks. But in many countries, there are still people who are a little bit afraid of internet, for example, or they live at countryside where the bandwidth is not that good, or the gadgets are not that good. So, do you have from meeting all these people with Parkinson's disease, but also other such diseases that you cannot really heal or cure anymore. You have to just live with. But so what are the options for people who don't have maybe access to internet and those global networks? Also, maybe you mentioned that language could be an issue there, for example.
Yeah, no, that's a very good question, and I often talk about that, because even here, I mean, here in the US, 3 hours away from New York City, the internet connection is very bad, it's very weak if you have it. So in that case, what I've seen worked, there are some mentoring programs. For example, there's one here in the US that's called Twitchy Woman. That's how it began. And of course, the initial part, you do need an internet connection to get in touch with them, but they also have phone numbers, regular phone numbers. So it's important that MDS doctors, which again may not be available near you either, but your neurologist or your primary care physician or general practitioner, whichever the word or the term is in each country, that they know that these resources exist. So I think there's also a responsibility from these resources, from the networks, towards the doctors who are there, towards the communities. And for example, through Twitchy Woman, I participate as a mentor. It matches women who have been recently diagnosed with women who have a longer track for more experience. So the woman that I speak most often, she does live in a place that the internet connection is not very good, so we speak mostly on the phone. So we have that. There's that option. You know, the regular phone, usually landlines still work, so that's definitely always an option. Then because support groups, maybe that's also a problem, because you might be really the only woman in miles or in kilometers who has Parkinson's disease, so you don't have a way of having a support group. But you might find options like this, speaking on the phone, or even having maybe someone at the doctor's office, at the clinic, maybe someone who has experience in support groups or in Parkinson's disease or in chronic diseases in general.
Mm-hmm. Yes, maybe even one option is the support groups that churches, for example, offer also for caregivers sometimes, because this is again another option for empowerment, of course, learning from options that other people go through or experiences, and sharing your own experiences. So that is probably what is at the disposal for people who live in isolated areas or rural areas. That's so yes, there might be, but you of course have to go this extra mile to reach out. So and this encouragement probably has to come from healthcare provider, and this knowledge that where help can be found, additional help.
Yeah, so that we also talk often about that, you know, just displaying some brochure or a leaflet at the doctor's office, because you're sitting there sometimes, you know, for a long time without having much to do. And now, I don't know in Europe, but now, of course, you know, with COVID-19, we're very spread apart when you're in the waiting area, and there's no reading material. But that doesn't mean that you cannot have something hanging on the wall, right? And have, you know, a phone number, even if it's just a phone number, that would be more than nothing.
Yes, but now we come to some very special issue, which I think is really a huge problem, and unfortunately our time is limited and we will not solve this. But we know that nowadays women can do everything. They can be everything and become everybody, and basically there are no limits. Yet we have to be more perfect, more healthy. We cannot allow any mistakes, and so on and so on. That is the life of women nowadays. You know, it's there is no limit, sky is the limit, but it comes with a cost. And you mentioned it also, that you don't have time to go to the doctor, and so when you notice the first symptoms on you, and then we have the other end there, that specialists, neurologists with good knowledge are very rare. So in your case, in your personal case, how did this happen now? That at which point in your life, busy professional woman, and of course, yes, in a life period also, maybe, changes happen to your body also, and you think, okay, maybe it's part of this natural process, and kind of we also know very little about. So when did you decide that now it's time to go to doctor, and then something is wrong with me? So how did you notice that?
Yeah, so my first symptoms were my handwriting that got tiny. That it was that you couldn't really read it. I did have a little bit of tremor, but not that much. It wasn't very very pronounced. But I noticed my right leg was dragging a little bit. So I went to see my PCP, my family doctor, and she misdiagnosed me, which is, I mean, it's not her fault. I mean, it's something that happens very often, as I said. She said, "Oh, you have essential tremors." Catherine Hepburn, it's an example, and here's a prescription for something that, of course, didn't work. In my particular case, I have a friend who's a neurologist. She works in epilepsy. Here in the US, when you specialize, you really specialize. So she's still a neurologist, but different field. And she said, "I think you should see a movement disorder specialist, just to check." And so in that sense, I was lucky, because within 6 months of that essential tremor diagnosis, I got my Parkinson's disease diagnosis. But I know that that's not usually the case. Most of the stories that I've heard, even from people who work in the healthcare system themselves, have had issues, from they first go to check any other doctor but a neurologist, and they go around, they get because we don't fit the profile. We don't fit the profile of the old man having issues. So that's another thing. Like, we have to make sure that we try to get this message across. Don't rule out Parkinson's disease every time you see someone who's young, because that might not be the case. Yeah, maybe you try, the essential tremors first, because that's more common, but refer your patient to a neurologist, ideally to a movement disorder specialist. But we know that there are not that many. For example, in Uruguay, there are no movement disorder specialists. There are neurologists who are very good at Parkinson's disease, but no specialists. So that was my particular case. So I was lucky in that sense, that I didn't have to, go around and go to see different doctors. I know of cases of women who were told that they didn't have Parkinson's disease, and then it was actually that. In many cases, also what happens, there've been also a few cases in which women are diagnosed either after giving birth to a baby, or around menopause. So there are some indications that there's something going on with estrogen levels and different things that might play a role. And that's also why it's important, this survey that I was telling you about, the survey being done in Spain, because it's going to look into that. There's also a survey being done internationally here in the US, because we have to look into that. There are differences. We know my medication doesn't work the same when it's before my period. There are changes. There are definitely clear changes. And there's a reason for that. We think it might be estrogen, but we don't know. For that, we need research.
Mm-hmm. Yeah. Well, we just saw that 2021, I think, The Lancet had at their cover even the word menstruation. So I think we are moving forward, but there is still lots of work to do, and I think that it is essential that we find also language to speak about women's bodies and their bodily needs and also changes, and that we get people to listen to that as well. Not to mention what life expects from us, even and being constantly tired, being part of women's life experiences. This seems to be one of the pandemics that we live, and then we end up very lonely at the end of life, which happens to many women as well, with little resources and high out-of-pocket payments, because there is an economical side to every disease as well. And I think it affects women in particular because their dollars and euros are lesser than male dollars and euros. So and that affects also what options do we have at the end of life, for example, or when we are older, let's say, and we cannot provide for ourselves anymore.
Mm-hmm.
Is it you also mentioned that if you have a chronic disease and a diagnosis, then you think about mortgages and things like that. So maybe you can also tell a little about this economic aspect.
Of course, yeah, and it's something that we don't talk about often. I don't know if it's because it's a taboo. You don't talk about money, like you don't talk about menstruation, but it's very important. And just I was reading a study that it was done in Spain specifically about Parkinson's disease, the burden of Parkinson's disease, and they said it would cost around 17,000 euros a year, which is for Spain is a lot of money. It's quite a lot of money, and of course that included costs that are borne by the government, by the healthcare system. But I think that calculation, and any calculation, very often any burden calculation, in the past has missed other costs, like for example, if I have a bathtub at home and I have to replace it by a shower because I cannot get in the bathtub, that's not covered. That's not considered. That some countries maybe, but usually it's not. If I have to take a taxi to go to the doctor because there's no public transportation nearby, or in some cities, and this I'm referring specifically to Spain, there are cars parked at the bus stop. So the bus cannot get close to the sidewalk so that the person with a disability, not even only Parkinson's, but with any disability, can get on the bus. So these are things that people don't take into account. Or, for example, that people with Parkinson's, we are more prone to falling. So if I fall and I break a bone and I need surgery, that cost is also part of the Parkinson's costs. So that's not also considered. And as you said, the pay gap, and we're not talking about, just equal remuneration for equal work, which should be the case, should be applied everywhere. But that's going to influence my pension in the long run. So my access to, as you were saying very very aptly, my access to end of life, or not even that. I mean, just assisted living might be different because my pension is lower than that of a man. So how do we deal with that? How do we deal with the fact that physical therapy is not included in the healthcare systems in many countries when we need it? I mean, it's been established that physical therapy helps people with Parkinson's in this case, and in many other chronic diseases. Speech therapy, even exercise. Why isn't exercise subsidized when it's why is I have to pay for a gym membership, but I don't go to the gym because I enjoy it necessarily. Maybe I do, but because I need it, because it's part of my prescription. As I said, is take your meds, exercise, see your care team. So why in that case? Of course, there are some systems, and even here in the US, there are some systems that do subsidize the gym memberships, but maybe they are lacking in other things. So let us not, get too excited about that. So yeah, and even mental health, as I said earlier, very often mental health is not part of the insurance plan. So people have to pay out of pocket, and maybe you have to pay hundreds and hundreds and hundreds of euros or dollars before you get some sort of reimbursement, if any. But again, that's been established that you need that. So why is there that disconnect? And again, it's not about feminism only. I mean, feminism is different. I mean, this is a direct application of what we need in life and what our needs are for real to have quality of life, and maybe not to improve it, because sometimes you cannot improve it, but at least to maintain it, to keep a level of dignity, of autonomy and empowerment, like I was saying, and with these things that make my life livable and bearable, not only for me, but also my family members and the people around me, of course.
Yes, yeah, I totally agree with you, and I am conscious of our time, which I already predicted will be too short for this discussion. But because we speak about, we already mentioned the end of life, and it is not only the terminal phase where you maybe don't have control anymore about what is happening to you. But the end of life kind of starts with the diagnosis of a chronic disease, because okay, your time is limited, because people without diagnosis maybe sometimes imagine that it is not like this. This death awareness is not really part of our culture very much. You mentioned those. There are mainly men who lay down in the coffin and let them be carried around. So maybe that's something. There's something there, So I think women also, when they become a parent, they understand that death is like so close, and it is our destiny. So and maybe there is more death awareness in women anyway, but we don't know that. Of course, that is just an hypothesis. But now when we think, okay, there is this palliative care, and palliative care movement is a global movement. And we have this difficulty of making people understand what palliative care is about. 40 years ago, or 40 years already, we want to make palliative care available for people. And still it is hospice, it is end of life at palliative care units or in palliative care units. And it is only like, let's say, the last 2 weeks of life. And even those services are based on philanthropy in many countries. So just a wild guess. Why? Because you are behind a global movement. So why is it like this? And what do we have to do to change this, to make palliative care, this kind of holistic support for people, available? Mm-hmm. What is your hunch or gut feeling here? Yeah. Or maybe you have some evidence that I don't have.
No, but it's true. It's true. I think that the reason why it happens is because across all cultures, I think, or most cultures, or Western cultures, I should say, we don't talk about death. Just like we don't talk about illness. Those are things that we hide. If there's a death in the family, you don't want the children in the family to know about it, to see the dead person. So everybody's going to die, but we don't want to talk about it. Like, we don't talk about illness. So I think that's one of the many reasons why this happens, is that you don't talk about it because it's bad. And then when we're faced with it, we don't know how to react, right? And we don't know what to say when we have to give our sympathies to someone. So I think that's one of the things, that one of the causes, perhaps. How to deal with it, how to avoid it, how to get over that sense that palliative care is only hospice and morphine when you're dying. This outreach, talking about it, bringing the message to anyone and everyone, and doing it a little bit in a pyramid way. You start from you, and then you pass on the message to the next person, and this person passes the message to 2 people, and these 2 people pass the message to 3 people. So I know that those schemes are illegal in financial terms, but for the spread of communication, I think it's very important, because the minute you take palliative care outside of the usual circles, outside of your circle in this particular case, and you bring it to the patients, for example, like you're doing now, you're already taking a step forward, or outside of the circle, because then I'm going to be talking about it to someone else who might not have any connection with Parkinson's, and they might find it useful. So this is the cascade effect, almost, I think, is the way to do it. And I'm a firm believer of grassroots movement. I think that the change comes from the bottom up more than it will come from the up down, because you start spreading. Of course, you need someone to, like you, Pire, that you have your talks and your presentations and your things, and you teach us about palliative care. You and many other people and specifically neuropalliative care also. But the minute you start spreading your information, and that starts going to other people, that's how it's going to happen. And I think it'll happen much faster, thanks again to technology and to the fact that people are less afraid of talking about it. And they are, I never thought of that. But you mean that palliative care is not the priest in the Catholic world? You think about the priest who comes with the last rites, and that's another thing in the Catholic system or world. One thing is the last rites, but the other one is the sacrament of the sick, which you don't give that to the person who's about to die. You share that with anyone who's going through sickness, who's going to have surgery, but that doesn't mean that it's the last rites, that they're going to die. So that's another change. That's a big change, but that's of course confined to the Catholic culture more than anything else. But and then of course, and we haven't talked about demons and and all the paranormal that you so aptly touched in your talk in the International Neuropalliative Care Society, because that's, again, we could be talking for another hour or so about superstition and all of that.
Yes. So I think that we have to stop now, but our discussions will continue, of course, and we hope that the listeners and watchers of this unit will get some impulses and will be part of this pyramid that at one day will stand like the pyramids in Egypt, and we have also palliative care at everyone's disposal at any point of time, at any stage of life, just when it is needed, and that it will be trans and multidisciplinary, and that we have a healthcare system that is also adapted to women's needs, and also that it doesn't present itself with too big gaps that then every individual has to cover somehow or get over with somehow. So, Isabella, any famous last words for this session?
Just keep fighting. I know that some people don't like the use of war terminology, but it's the best. It's so good. It describes very well. It's keep going, keep moving forward. Stop when you have to stop. Know that you're not alone. That's very important. I know that many of us feel alone when we're diagnosed with any chronic disease, but you're not alone, and a lot of people are out there who are willing to give support. So go reach out.
Thank you very much.
Thank you, Isabella.